My name is Thomas Daniels. I'm a radiation oncologist who treats prostate cancer. Many prostate cancer patients face a choice when they are deciding which treatment is best for them. There are several available options for radiation for these patients. Here at the Mayo Clinic, we have several standard types of radiation to treat prostate cancer, as well as other types of treatments that are less common. To decide which type of radiation treatment is best for you or for your candidate, you need to be evaluated by a radiation oncologist. Part of the evaluation would include a physical examination, a review of your pathology, as well as a PSA. After that, we'll have the information that's needed to decide whether or not additional imaging studies are required, such as a CT scan or a bone scan. Before you start radiation, several things would need to be done to get you ready for the treatments themselves. We would need to place fiducial markers into the prostate, and these allow us to take a picture of the prostate and visualize it so we can make some last-second adjustments before the treatment is actually delivered each day. Before we treat prostate cancer, we also have to stratify which risk group the patient falls into. Part of this evaluation would require us to know your Gleason score from your biopsy, your PSA, and your physical examination. Once we have those, a determination is made whether or not additional studies are needed. Prior to radiation, we would need to place fiducial marker seeds into the prostate. We would do a radiation treatment planning CT scan, and our practice here is also do a radiation treatment planning MRI scan. After these have been completed, we will bring you back a week or two after the simulation, and you can start the radiation treatments. The prostate is right in front of the rectum. That's the reason why a doctor will often do a digital rectal examination for patients with prostate cancer. When we treat the prostate with radiation, the rectum also gets some radiation. Nowadays, there are things that we can do to minimize the amount of radiation the rectum gets when we do radiation. One of these is to place a hydrogel spacer. This causes a separation between the prostate and the rectum, so the radiation does fall off into the spacer itself, and this will lower the amount of radiation that the rectum receives while still treating the prostate to a very high dose of radiation. This is a procedure that needs to be done prior to simulation. In order to do so, a needle has to be placed between the rectum and the prostate, and a material is injected there which forms a separation, allowing us to spare the rectum when we do radiation. Treatments last approximately 15 minutes, although the majority of this time is actually getting you set up in the same position that you were placed in during the radiation treatment planning simulation. Many patients are candidates for radiation, but we have to evaluate your urinary function prior to your starting the radiation treatments themselves. Often patients with prostate cancer also have urinary obstructive symptoms, which require us to either give medications or to have procedures done by the urologist to optimize the urinary function before we start radiation. A common question after radiation is whether or not you've been cured of your prostate cancer. For this, we do the same blood test that was done at the time of diagnosis, something called the PSA, or prostate-specific antigen blood test. If your PSA goes down after radiation with or without hormonal therapy, and if it stays down, we consider you to be cured. If the PSA rises after treatment, then we take pictures to see if the prostate cancer has spread anywhere else in the body. Generally, the treatment for progression with a PSA, or if the tumor is spread, is to treat with Lupron therapy at a minimum. Lupron therapy is often done in conjunction with radiation, as patients who have had more advanced Gleason scores and more advanced prostate cancers benefit from Lupron therapy in addition to radiation. During radiation treatments, patients often feel that they have to urinate even if they don't have to urinate. It's not uncommon for the radiation oncologist to prescribe certain medications, such as Flomax, to the patient to help ease their urinary symptoms. There are also other medical treatments available. An uncommon but not unheard of complication after radiation is that scar tissue can form within the prostate itself. This is something called a urethral stricture, and this has to be addressed by the urologist. Radiation can cause side effects both in the short term as well as in the long term. Short-term side effects are things that happen during radiation and might occur for several months afterwards. Long-term side effects are things that might or might not happen months to years after completion of radiation. Common short-term side effects from radiation include the sensation of the need to urinate when you don't need to urinate, and an increase in the need to go to the bathroom during the day as well as during the night. Generally, these symptoms get better after you've done with the radiation, but this can take several months. Long-term side effects are the side effects that can happen after radiation, even months to years afterwards, include urethral strictures. Often patients also complain about having dry ejaculations after treatment, and there can also be impaired sexual function after treatment with or without Lupron. In the long term, side effects from radiation can also include radiation cystitis, and this is a situation in which the bladder can become inflamed at the base from where there is some radiation when we treat the prostate cancer. Over time, small blood vessels can also happen in the base of the bladder. It's not uncommon for the base of the bladder to get some radiation because of its proximity to the prostate. And over time, these small blood vessels can open up and patients can have some blood that comes out of the urine. Months to years after radiation, it can happen the patient can have small blood vessels that form in the base of the bladder. This is part of the bladder that gets some radiation when we're treating the prostate. If this were to happen, or if there would be inflammation in the bladder secondary to radiation, the patient would need to be evaluated by a urologist. The urologist often has to perform a procedure called a cystoscopy and potentially instill medications into the bladder if this is the case. One of the potential long-term side effects that we worry most about is something called a secondary malignancy. Radiation can be used to cure cancer, but in rare instances, years after treatment, it can also cause cancer. Because we're treating with ionizing radiation, this is always a small risk years after treatment. One of the benefits of proton therapy is that less of the patient receives radiation, whereas the target that we're trying to treat, the prostate itself, receives radiation with this treatment or with the standard treatment called IMRT. There's a theoretical benefit to proton therapy in the risk of reducing secondary malignancies because less of the patient and less of the non-target tissue gets treated by radiation. With any form of ionizing radiation, there is a theoretical risk of secondary malignancies years after treatment. Radiation can be used to cure cancer, but it can also cause cancer years after treatment. There's a theoretical benefit to protons in that there would be a smaller risk of radiation-induced malignancies years after treatment with protons versus standard radiation. One of the most common questions that patients have is whether or not they've been cured of their prostate cancer after radiation. After radiation, with or without hormonal therapy, your PSA should go down. A recurrence of your prostate cancer, or more specifically a biochemical recurrence of your prostate cancer, happens when your PSA goes up after treatment, but it must exceed whatever its lowest point was after treatment plus 2. So if your PSA went down to 0, a biochemical recurrence would be considered a PSA after treatment of 2.0. If your PSA goes down to 0.5, then we would define a biochemical recurrence as a PSA of 2.5 after treatment. If there's a recurrence after radiation, so if your PSA goes up to 2 plus whatever its lowest point was after treatment, this being the definition of a biochemical recurrence, then we would take pictures to see if there were any evidence of prostate cancer anywhere else in the body. Generally, the mainstay of treatment for a PSA recurrence after radiation is Lupron therapy or additional Lupron therapy if the patient has received this. If the images taken in the instance of a PSA recurrence show that the prostate cancer is spread to some other part of the body, the lymph nodes or the bone scan, a referral will often be made to a medical oncologist. This is a cancer doctor who specializes specifically in treatments such as chemotherapy. Generally, Lupron therapy is the mainstay of treatment for a biochemical recurrence or a metastatic recurrence of prostate cancer, but additional therapies are also done at the discretion of the medical oncologist. If there's been a recurrence of prostate cancer and the imaging shows only a small number of areas on the PET scan or other imaging studies, then we also have the possibility of doing radiation to those areas in conjunction with Lupron therapy. This is a situation that we would define as the patient having something called small volume oligometastatic disease. Generally, this is defined as having 3 or fewer lesions, be they in the bone or in the lymph nodes, which we suspect are prostate cancer that is spread after definitive treatment. Recent studies have shown that aggressive treatment of small volume metastatic disease can be beneficial if the patient is also responding to Lupron therapy. For patients who have metastatic lesions that require treatment with radiation, we have the option of doing standard radiation techniques or something called stereotactic body radiation therapy. Stereotactic body radiation therapy is a form of radiation where we give radiation to very high doses over a very short period, 5 days or fewer. For some patients with prostate cancer, stereotactic body radiation therapy, and once again, that's radiation done over the course of 5 days or fewer to a small area, to high doses. This technique can also be used for some patients who have prostate cancer that is not spread. An emerging technique for treatment of prostate cancer is the utilization of stereotactic body radiation therapy. Stereotactic body radiation therapy, also called SBRT or SABR, stereotactic ablative body radiation, is a way of giving radiation to a small area with very high doses over a very short period. This can be done as definitive treatment for some patients with prostate cancer. SBRT can also be used for patients who have prostate cancer to only a few areas that might have spread after definitive treatment of their prostate cancer. For patients with prostate cancer, radiation can be used as definitive treatment of their prostate cancer. There are several different ways to approach this. Older studies utilize both whole pelvis radiation, followed by additional radiation, also called a boost, to the prostate. Other studies have shown good results with treatment of just the prostate itself. Currently in our practice, for patients who have no evidence of disease that is spread outside of the prostate, more specifically, for patients who have no disease that we can see in the lymph nodes, our practice is to treat the prostate by itself and omit radiation to the pelvic lymph nodes. Prior to making a decision about what the best treatment is for your prostate cancer, it's best to solicit as many unbiased opinions from the professionals who treat prostate cancer day in and day out. Thank you for your attention. My name is Thomas Daniels, and I'm a radiation oncologist who treats prostate cancer. If you have any other questions about prostate cancer, please feel free to explore the other sections on this website.